tell, there are many variations since then. Today we're going to talk about the profunda artery perforator flap, the PAP flap, in 2010, and 2011, the thigh gluteal artery perforator flap, the TGAP. To this date, we have performed 52 PAP flaps and 2 TGAP flaps. The posterior thigh flap has been described by many surgeons. It is either from the inferior gluteal artery or from the profunda femoris artery. In cadaver studies, the main blood supply to the posterior thigh is the profunda femoris artery by the 3 main perforators shown in the purple area. Here's a cadaver dissection. Notice the marking. And here is the dissection. We'll go more into detail later. Our indications for this particular flap is a failed reconstruction when the abdomen is non-available or patient's preference is thigh over the buttock region. Each of our patients undergo an MRA or CT angio to identify the perforator and intraoperative mapping. The surgical planning the patient is seen the day before surgery where the markings are placed. Usually the flap measures 27 by 7 centimeters. The superior marking is at or 1 centimeter below the gluteal crease, and inferiorly about 7 centimeters below that border. Medially is the mid-gracilis, and laterally is the lateral extension of the gluteal crease. When we perform the flap harvest, we incise to the muscle fascia with inferior and lateral bubbling to incorporate as much fat as possible. We avoid bubbling above the gluteal crease to preserve the contour. And when we are near the perforator, we incise through the fascia. The pedicle dissection is usually subcutaneous between the adductor magnus and the semitendinosus, but it can be within the adductor or more lateral. And the pedicle length is roughly 9 centimeters. When closing the donor site, the inferior posterior thigh is undermined and advanced superiorly. It's suspended and anchored to maintain that gluteal crease. And then the skin is closed in multi-layers and a drain is placed. Here is a clinical example of a patient with a failed implant on her left breast. This is a preoperative MRA. L2 shows the perforator off of the profundus, and this is the perforator we'll be using in the OR. Here's an MR 3D reconstruction that actually shows us exactly where that perforator is on the skin of the posterior thigh. And then this is us creating the marks around the perforator, and the mark, the inferior mark, is where we audibly heard the perforator by a handheld Doppler. So here we are intraoperatively dissecting the pedicle. You can notice the pedicle length. This one is roughly 9.5 centimeters. It has a good caliber and a good match for the internal mammary artery and vein. Here's the flap independently. It's in a crescent shape to be allowed to be combed, and notice the pedicle. The flap is positioned into the breast pocket, anastomosed to the IMD and IMA, and then it's combed to form a natural teardrop shape. And here she is postoperatively before her skin island was removed. Notice the gluteal crease, the symmetry in the form. This next patient is a BRCA-positive mutation. She underwent bilateral nipple-sparing mastectomies with glandular replacement with the PAP flap. You actually can see in this picture that we actually got more volume than her native breast tissue. The next example, again a nipple-sparing mastectomy from a BRCA patient. And to point out, the perforators are a little bit lower in this particular patient. And that's going to be important when we talk about the TGAP. Here she postoperatively. She has good form, good symmetry. This is a patient, another patient, BRCA patient, who had actually an invasive carcinoma of the left breast, underwent a lumpectomy and has a defect. And this is her before the cosmetic part of her second stage with the PAP flap. Notice that her gluteal crease is symmetric and her posterior thigh is smoother. This is an interesting case. This was sent to me by an outside surgeon who performed bilateral DIEP flaps. The left flap failed and he put a tissue expander. The patient came to me for a unilateral PAP. Interoperatively, however, we were short volume. So our decision could have been to either fat graft at a later date or place an implant, but we decided, based on her body habitus, to perform a simultaneous intercostal artery perforator flap. And as you can see, we have nice volume and nice shape. She went back to the subsequent surgeon for her aesthetic procedures. And this is the buttocks crease. We have one donor site seroma. We've had 2 fat necroses and 1 recipient and donor site hematomas for our complications. So the advantage of the PAP flap, the long pedicle, thick tissue in a long elliptical shape, optimal, coning of the breast, no disturbance of the buttocks contour, no disturbance of the ischial fat path, a well-hidden scar, an adequate perforator always present. So I'm going to take a few moments to talk about the TGAP. The inferior gluteal perforator located below the crease. It's a subcutaneous vessel. The pedicle length is 8 centimeters, and it's a sensate flap. Here's the MRA of the TGAP. This is again off the inferior perforator, inferior gluteal perforator. And here's the patient pre and post. And here's she post operatively. The advantage of the TGAP flap over the PAP flap is that when I showed you the picture prior, where that PAP flap, the blood supply was a little bit lower, which subsequently can cause the scar to be lowered. The TGAP flap, the perforator is right at the inferior gluteal crease, which is an advantage when we really want to preserve the inferior gluteal crease. Another example of nipple sparing, and again the crease is preserved. So the PAP and TGAP versus the TUG flap. No muscle, no anterior scar, no lymphedema, longer pedicle, and it can be harvested supine or prone. In our practice, we mostly supine harvested. In conclusion, the PAP TGAP is to the TUG as what the DIEP SIEA is to the tram. Thank you.